Hello everybody, thank you for joining me today, and in today's video we're going to be looking at the high yield obstetric emergencies for finals. Now this is part of my Obs and Gynae edition, so let's get started. So the medicine guide aims to support medical students throughout their entire journey at medical school. So I've made videos such as how to be successful in the pre-clinical years at medical school, so that's years 1 and years 2. How to be successful during the clinical years at medical school, so that's years 3, 4 and 5. How to get the most out of GP placements. How to get the most out of hospital placements. How to be successful in your clinical OSCEs. And I've got another edition focusing on the high yield paediatric conditions such as high yield child with vomiting, high yield congenital heart disease, high yield rashes for finals, high yield limping child for finals, high yield genetic conditions for finals, and high yield child with a mass. So like I mentioned previously, this video will be part of the Obstetrics and Gynecology edition. So other videos in this edition includes high yield chronic abdomen, high yield gynecological cancers. So this video will supplement the acute abdomen for finals, high yield obstetric emergencies for finals, which is this video, and high yield STIs for finals. So let's get started. So in today's video I'm going to be focusing on these 5 high yield topics which crop up time and time again in finals. So I'll be covering cord prolapse, placenta previa, placenta abruption, uterine rupture and shoulder dystocia. So our very first condition is cord prolapse. So a cord prolapse is when the umbilical cord is presenting before the presenting part of the fetus. Now the presenting part of the fetus might sound a little ambiguous, but what it really means is that it's describing the part of the fetus that's seen first. So when the baby's been born, the baby is either born in a cephalic position, so that's when the head comes out first, so then the presenting part would be the head, or the baby may be delivered in a breech position, so this is when the feet come out first, so then the presenting part of the fetus would then be the feet. So going back to the definition, the presenting part of the fetus is just describing the first part of the fetus which is being delivered first, so that could either be the head or it could be the feet. The most important thing in a cord prolapse is that the umbilical cord is presenting before the presenting part. Now there are 2 types of cord prolapses. There is an overt cord prolapse, so that's the first picture, and then there's an occult cord prolapse. So an overt cord prolapse, as you can see, is descending before the presenting part, so it's descending before the fetal head, whereas the occult cord prolapse isn't. So that's something just to keep in the back of your mind. Now we need to focus on the risk factors for cord prolapse. So the risk factors of a cord prolapse includes a breech presentation, artificial rupture of the membranes, a transverse lie, so that's when the baby is lying horizontally across the mother's abdomen, a twin pregnancy, prematurity and placenta previa, and I'll explain placenta previa in the remainder of the video. Now I've highlighted artificial rupture of the membranes in purple and I've underlined it because classically in SBAs it will involve a scenario where a woman has had an artificial rupture of the membranes and then a complication such as a cord prolapse will occur. So it's really important to keep in the back of your mind that a major risk factor for cord prolapse is artificial rupture of the membranes, and this tends to be a very typical SBA scenario that crops up in exams. Now let's focus on the signs and symptoms of a cord prolapse. So a visible cord is seen beyond the level of the introitus. The cord will be palpable in the vagina and an abnormal fetal heart rate will occur. Okay? So let's focus on the management. So the immediate management is that the mother needs to be on all fours, and this may sound a little bit ambiguous, but on all fours relates to this picture that you can see on the right. So essentially, the woman's hips are being elevated, and the whole purpose of doing this is that it allows the baby to be shifted off the pelvis to reduce any cord compression. Now, the definitive management of a cord prolapse is that an immediate C-section is needed. Okay, so just be aware with cord prolapse, the initial management is that the mother needs to be on all fours, but the definitive and ultimate treatment for this is that an immediate C-section is needed. Okay, so now let's move on to placenta previa. So in a placenta previa, this can be described as a low-lying placenta. So this is when the placenta will implant itself partially or completely over the internal cervical os. So if you have a look at the diagram, you can see there's a spectrum from type 1 all the way to type 4, where type 1 has the least severity, but type 4 has the greatest severity. And you can see this all depends on the level of occlusion of the internal cervical os. Now let's look at some of the risk factors. So some of the risk factors involves a previous C-section and uterine surgery, and that's because after having these procedures, sometimes it can lead to scarring, and for whatever reason, in future pregnancies, the placenta prefers to implant itself over this scarring lower region, and that's how it can contribute towards being a risk factor for placenta previa. Other risk factors involves a placenta accretia. So this is when the placenta is invading the myometrium and becomes inseparable from the uterine wall. Other risk factors involves twins or triplets, because in this scenario there will be multiple placentas developing alongside with the babies, so there's a greater risk that any one of those multiple placentas could overlie the internal cervical os and therefore lead to a placenta previa. Okay, so in terms of the signs and symptoms, placenta previa presents with a sudden painless vaginal bleeding after 20 weeks gestation. So a woman will be presenting after 20 weeks gestation with sudden painless vaginal bleeding. Now this bleeding will be a fresh red vaginal bleeding. The uterus will be painless and non-tender, and usually there'll be an abnormal lie, so the baby may be in a breech presentation. So that's when the baby is presenting with a feet first presentation. There'll be a normal fetal heart rate, and shock will be in proportion to the visible blood loss that the woman has suffered from. Now I've highlighted painless and underlined it as well, because this is one of the key features which helps to distinguish a placenta previa from a placental abruption. So I'll discuss placental abruption later on in the video, but we need to recognise this placenta previa is typically and commonly a painless vaginal bleed, and that's important because in SBAs they often ask you to compare, contrast and distinguish between placenta previa and placenta abruption. So just remember, for placenta previa it will present with painless vaginal bleeding. Now the next question is, how is this managed? So typically a ultrasound scan is diagnostic for placenta previa because it confirms the low-lying placenta, which is partially or completely occluding the internal os depending on the degree of its severity. So after the 20-week prenatal ultrasound scan, the ultrasound scan is repeated again at 34 weeks. So at 34 weeks, if the placenta previa is identified as either a type 1 or type 2, then a scan is needed every 2 weeks, whereas if the ultrasound identifies either a type 3 or a type 4 placenta previa, or if there is an abnormal lie presenting at 37 weeks, so this can either be a breech presentation or a transverse lie, for instance, then a C-section is needed. Okay? So placental abruption. So there are 2 types of placental abruption. There's a revealed abruption, and this is when part of the placenta is pulling away from the uterus and you can see visible blood loss. But a concealed abruption is when blood is collecting between the uterus and the placenta and no blood is visible in the vagina. Okay, so that's 2 concepts to keep in your mind. Now, in terms of risk factors, preeclampsia, multiparity, so that's where a woman has had multiple pregnancies, abdominal trauma, an ECV, so an external cephalic version, and past medical history of placental abruption causes a woman to be at greater risk of developing a placental abruption. So an example of abdominal trauma could be a road traffic accident, which induces a degree of assault, and therefore that's a risk factor for placental abruption. So in terms of the signs and symptoms, the woman will be in sudden, consistent and constant abdominal pain. They will have a tender, hard, woody uterus, painful, dark vaginal bleeding. They will have a normal lie and normal presentation, but the fetal heart rate will be absent. So, like I said, it's very key to be able to differentiate between the placental abruption and placenta previa. So, placenta abruption is when the woman will be in constant abdominal pain. So the uterus might be described in the SBA as feeling hard and woody, and the fact that the vaginal bleed is a dark vaginal bleed, that implies that the bleeding has been occurring for quite a prolonged period of time, whereas in a placenta previa there will be a fresh red vaginal bleed. Okay? So in terms of tests, it's a clinical diagnosis, so we need to perform a group and save, perform a rhesus and Kleihauer test, so this is particularly important in women who are rhesus D status negative, a renal function test, as well as performing a CTG and an ultrasound scan. So in placental abruption, it's important that the fetus is delivered regardless of the gestational age, so steroids are needed to help allow the fetal lungs to mature. So typically the steroids that are used to help the fetal lungs mature involves dexamethasone and sometimes beclometasone. So the next condition that we'll cover is a uterine rupture. So a uterine rupture is a complication of labour where the myometrium, so that's the muscular layer of the uterus, ruptures. So the risk factors of a uterine rupture includes a vaginal delivery after having a C-section. So if a woman had a C-section in her previous pregnancy, I've mentioned in the video previously that it does lead to some degree of scarring, and if the woman decides to have a vaginal delivery in her current pregnancy, then unfortunately one of the complications is that the uterus will rupture along the level of the scarring segment from her previous C-section. And similarly, that's also why uterine ruptures can occur following uterine surgery. So again, there's that degree of scarring, and unfortunately with labour it can lead to a uterine rupture. Also, other risk factors include induction of labour and a high maternal BMI. Now, what are the different types of uterine rupture? So we've got two types. There is an incomplete rupture and a complete rupture. So an incomplete uterine rupture is when the peritoneal lining surrounding the uterus is intact. A complete uterine rupture is where the peritoneal lining surrounding the uterus ruptures, and therefore the uterine content is then released into the peritoneum. Now, in terms of signs and symptoms, there will be an abnormal CTG, the woman will be in continuous abdominal pain, and she will suffer from vaginal bleeding. In terms of management, we need to perform an emergency laparotomy and perform a C-section delivery of the baby. Now, after doing this, we need to repair the uterus surgically, or we can perform a hysterectomy. So hysterectomy is when the uterus is removed. Now, the decision to perform either a repair of the uterus or perform a hysterectomy will depend on whether or not the woman feels that she has completed her family. So if the woman has decided and feels that she has completed her family and that she will no longer want any further children, then a hysterectomy would be advised. However, if the woman feels that she may still want to have some children at some point in the future, and she feels that her family hasn't been completed, then a surgical repair of the uterus would be better. Okay? So now we're going to focus on shoulder dystocia. So shoulder dystocia is when the shoulder becomes lodged behind the pubic bone during labour, and as the baby is being delivered, the healthcare professional may be holding onto the baby's head to help guide its passage, but the combination of the neck being slightly pulled and tugged and the shoulder being trapped behind the pubic bone, it can induce strain upon the brachial plexus and then cause it to tear, and this is emphasised in the central picture. So babies that are at risk of developing shoulder dystocia are babies that are very large, because the larger the baby, it's more difficult for that baby to be delivered vaginally. So fetal macrosomia, or large babies, are a complication of gestational diabetes. Another risk factor of shoulder dystocia is prolonged labour. So complications of shoulder dystocia is that the child can develop fetal hypoxia and cerebral palsy. They can develop an Erb's palsy. The mother will suffer from a perineal tear. It can lead to a postpartum hemorrhage, and also the child might suffer from a fractured clavicle or a fractured humerus because of the fact that the shoulder is trapped behind that pubic bone. So Erb's palsy is something that is highly examinable in medical school final exams, because it's something that they could easily ask as part of obs and gynae, because it's a complication from a shoulder dystocia, or Erb's palsy is something that can easily present as part of the neurology SBAs. So it's quite important because it does cross over multiple medical specialities. So we'll focus this in just a little bit more detail. So an Erb's palsy is commonly known as the waiter's tip. So it's an upper brachial plexus injury, as you can see in the central picture. Now it typically is due to a C5 or C6 palsy. So if you have a look at the baby in the far right hand corner, you can see that the right arm looks abnormal compared to the left arm. And that's because this child is suffering from an Erb's palsy, and the Erb's palsy is affecting the child's right arm. So in the child's right arm here, they will suffer from a loss of sensation in the arm. They will have paralysis and atrophy of the deltoid, biceps and brachialis muscles. The arm will hang by the child's side and is medially rotated, so that's why it's known as the waiter's tip hand. And the forearm is extended and pronated. Okay? So a typical or classic description of this is when the child's arm is adducted, internally rotated or medially rotated, with a forearm extended and pronated. And that tends to be one of the classical descriptions that crops up in exams. So with shoulder dystocia, they might ask you to describe it like I've done before, or they might want you to recognise that it's a complication. With Erb's palsy, they may ask you to describe it like I've done, or they might ask you to recognise that it's a complication of shoulder dystocia, or they might even throw in this question as a way of trying to examine whether or not you can recognise the classical nerve palsies as part of neurology SBAs. Okay? So the management of shoulder dystocia is very important, and it's something that you need to be very confident in being able to manage in terms of your final exams. So the mnemonic that I use for shoulder dystocia is HELPER, so H, so call for help, because this is not a condition that you can manage by yourself. You will need a team of people to help support you in managing this patient. E stands for evaluating for episiotomy. So episiotomy is when you are making a cut in the vagina, and the whole point of doing this is that it helps to enlarge the vaginal canal. So if you have a look in a picture, an example of an episiotomy is that it can either be a midline episiotomy or it could be a mediolateral episiotomy. Okay? So L stands for legs. So McRoberts manoeuvre is your first line manoeuvre that you would perform for shoulder dystocia. So if you have a look at the picture, McRoberts position just involves flexing the legs and tilting up the pelvis, because it allows the pubic symphysis to be orientated, so it appears more horizontal to allow shoulder delivery and therefore delivery of the rest of the baby. Now, if this is unsuccessful, then we need to move on to further steps. So the next step after McRoberts manoeuvre is to apply suprapubic pressure, so that's P in HELPER, and this is just to help disimpact and promote the delivery of the anterior shoulder. Now, if this is unsuccessful, then we need to perform rotational manoeuvres. So enter rotational manoeuvres, so that stands for E in HELPER. So this is known as the Rubin or reverse wood screws manoeuvre. So in picture 1, so that's the picture on the far left, you can see that the healthcare professional is trying to rotate the posterior shoulder. And then if you have a look on picture 2, so that's the picture on the right, you can see the healthcare professional is trying to deliver the rotated shoulder. So this is an example of a rotational manoeuvre, or it might be described in other books as the Rubin manoeuvre or reverse wood screw manoeuvre. Okay? Now, after performing that manoeuvre, if you're still unsuccessful in delivering the shoulder and the rest of the body, Then you need to insert a hand and sweep the posterior arm over the chest and over the maternal perineum, because this is an attempt to remove the posterior arm and help to deliver the baby. Now, it's really important that you try to evenly distribute pressure across the humerus to prevent any fractures, because I've mentioned in the previous slides that a common complication of shoulder dystocia is fractured clavicles and fractured humeruses, because of the manoeuvres that are involved in helping to assist the delivery of this baby. Now, hopefully after this the baby should have been delivered. If not, then you'll have to roll the patient onto her hands and knees. Okay? So I just want to say thank you for watching my video today. I appreciate it has been quite a long video, but thank you for being such a trooper and staying to watch the entire video. I'd just like to say, if you enjoyed my video today, then please give me a thumbs up, please like my channel, and please subscribe to my channel, and also please share my video with your friends. I'd just like to take a few moments to raise awareness for the cervical smear programme. So this helps to identify women who might be showing cancerous lesions. So it's really important that women do attend, and according to the NHS statistics, 1/3 of women don't attend because they feel quite embarrassed. I just want to reassure some of the girls that might be watching the video today and encourage them to please attend the cervical smear programme. It only lasts for 5 minutes, and the impact of cervical cancer will last a lifetime, so it's really important that they do attend. Thank you all for listening today, and I wish you all the best with your final exam.